the chairman of the APELS group for allowing us to conduct a meeting outside the routine centers that he has been conducting. And I'm glad to say that this is the first ever meeting of APELS that is happening in India. Thank Professor Micheal profusely for the honor that is bestowed on us. Thank you so much, Micheal. Actually, Professor Micheal has been going around the world, actually basically training surgeons both for endoscopy and laparoscopy. He is a pioneer who has foreseen that both combination of endoscopy and laparoscopy and the cooperation between endoscopists and laparoscopic surgeons is going to be the future of what is going to happen in surgery. We at AIG are also very fortunate that our chairman, Dr. Reddy, has conceived this project, and we as endoscopists and surgeons actually work very closely here in this part of the world. Actually, for most of the delegates here, actually it's a rare opportunity to have this course in India because it's the first ever course. And I have with my Dr. Roy Patankar, who is also one of the board members of the APELS and also the course director of this course, to be present here to demonstrate and participate in this event. Again, I cannot talk the entire executive here from APELS group and the Olympus group for the support, and also the industry who supported this meeting. This meeting is purely based for 50 people who are going to be intensively trained in this course, and I hope that some of you will become so big that Professor Micheal might invite them to centers of excellence across the globe. Thank you again, Professor Micheal. With this, actually, I request Dr. Reddy to come and say a few words.
Thank you, GB. And again, Micheal, it's a great pleasure to meet you again after a long time and see you as energetic as ever with so many new thoughts. And so my association with Hong Kong was partly responsible for Endo and Lab coming together. In fact, I was invited first there very long back in 1985 by Sidney Chung. And I realized then that at the Prince of Wales Hospital, that it's most beneficial for the patients if endoscopists and surgeons work together. I think this category of trying to make physician endoscopists, surgeon endoscopists may not be the right thing. I think endoscopists are a separate category, and depending on the invasiveness, you become laparoscopy and so on. And even in so-called physician endoscopists, my colleagues here, they are Moh and others, and they become very invasive. So I think we have actually now the barriers are completely broken. So this concept of APELS, which would be endoscopy, laparoscopy training, especially for surgeons, I think is a great concept. And I think it's a great concept is supported by Olympus. And this is something we like to propagate very much. In fact, in our unit, we would consider that surgeons, in fact, I think before any of us gets into the endoscopy room, GV is there already doing his endoscopies and colonoscopies before us, and of course ERCP. So I think this is a very exciting era, and it's time that our junior surgeons also trained in all aspects of flexible endoscopy. We have a great team of, at least from the endoscopy side, I can talk about them. They're doing fantastic works in various things. And we have Zaheer here, who is probably one of the best, world's best organizer of animal labs. He's got huge experience. He's trained probably 10,000 people on animal labs since some time now. So we have a great team, and I hope that all of you enjoy your stay here at AIG. I hope it's very productive, and I'd also suggest that you enjoy your food here, because the AIG cafeteria is famous for its Hyderabad biryani. Thank you.
I request Dr. Roy Patankar just come say a few words before.
Thank you, GV. It's a proud privilege as an APELS board member to invite all of you to this course. And AIG is, in fact, if you like, the flagship or the torchbearer of this combined Endo-Lap approach. I've seen Nagi and GV, they've been together, I think, 30 years, Nagi? So this culture has continued, and I see these lines blurring between medical gastroenterology and surgical gastroenterology when you will work in unison, working together. I hope all of you have a great time in the next 2 days. This is going to be an intense course from 9 to 5. We have a lot of dedicated faculty who will be with you, and we are thankful to Prof. Micheal for allowing APELS to do its first off Asia sort of course. It is always in Southeast Asia, but GV and I have been fighting to get this course in South Asia for a while. And thank you, Micheal, and I hope we live up to your expectations. Thank you.
I also acknowledge the presence of two of our international faculty, Professor Tay and Professor Theo, who come from Singapore to do this. And again, from the surgical team, we have the entire team, Rohit, Sanjeev, Mahesh, and Shreyesh, who have been coordinating actually the animal lab and the theatre live transmission. Can I request Professor Micheal to come onto the stage, and then we can, and can I request Dr. Reddy and Roy also to come?
Good morning, ladies and gentlemen. It's great to be here in AIG. In fact, it's my first visit, although I was in Hyderabad 20 years ago. And I must admit, to me, it's like a new environment coming to a very modern city. And of course, AIG is very impressive as a hospital with reputation way ahead of itself internationally. So the first time I see the setup here, and I'd like to congratulate Dr. Reddy and GV for being such forefront runner of clinical endoscopy and laparoscopy performing in this hospital. My brief this morning is talk about how Endo-Lap surgery come about. And as you see, laparoscopic surgery only been about 30 years development. Now it become a gold standard for most surgical practice. But one must realize endoscopy is also over 30 odd years development. In fact, my first contact with this technique was 1985 when I came back to Hong Kong from UK, and I worked under the auspices of Professor Arthur Lee, and my mentor at that time was a man called Joseph Leung, and he is really the start of endoscopy really as a career in Hong Kong for a lot of surgeons and physicians. Now, I think the major advances in surgical care in the 20th century have been the development of endoscopic treatment and laparoscopic treatment. And both are a minimally invasive treatment, and really for the better outcome of our patient and have less morbidities compared to open surgery. Complicated slide, but this is what happened from the days of the gastric camera up to the present day of precision medicine, molecular imaging, endoluminal surgery. It's come a long way over the last 30 odd years. Gone are the days when I remember as a surgeon I have to do laparotomy for GI bleeding and maybe do gastrectomy. I think the younger generation now don't even see gastrectomy or GI bleeding anymore because it's all being taken care of by endoscopic means. Now, beyond GI tract bleeding, you can see here really a lot of the our surgical treatment have been taken over by endoscopic means, removing foreign bodies. Patient with obstructive jaundice, stone can be removed, and EPT, and all these are listed here, can be dealt with by therapeutic endoscopy. And laparoscopic surgery, for the first description in 1987 by a famous person called Mouret, French surgeon, who's passed away, but I had the privilege of meeting him in Vietnam when he was when he retired over there. And as a young surgeon then, I went up to congratulate him on doing the first operation. And he, funny enough, he told me, I wasn't the first surgeon. The first surgeon was a German guy. He got put in jail for doing this work. But I put pen to paper and I publish. That's people knew about lap surgery. And that's very true. You publish, people know what you do, and people recognize what you can do. And from then on, we had the various stage of development of lap surgery, doing all sort of procedures, and you can see some of them are actually now routine. Then to the present day, we have robotic surgery. Robotic surgery is actually a type of instrument that we use just like our laparoscopic instrument, but more refined. You still need a person to be trained to work behind these instruments to make it perform. Of course, the scope of laparoscopic surgery started from the appendicectomy up to even with post-operation being routinely performed. And of course, this has to become a general practice. But you know, these were the kind of difficulty as we went up. Now, as far as I'm concerned, both techniques can be used, but they have the limitation as well. So endoscopists sometimes cannot deal with lesion too large, so we have to give it to surgeon to operate on. And of course, if you try and do your removal of polyps in an area where it's difficult, like the flexure area behind mucosal fold, again, that is increase the risk of injury. Again, you don't dare to do it. Lap surgery, biggest disadvantage, we can't put a hand into the abdomen to feel for the lesion. But that's overcome now and by endoscopy. So we can mark the tumor, early tumor, and Indian ink the tumor. For me, the concept of endo-lap surgery came about early 2000. I was sitting on a Bali beach, having attended the ELSA meeting. And I said to my colleague, who was then the manager of Olympus, I said, why do we have to do endoscopy in the endoscopy suite? Why can't we do it in the OR? I said, wouldn't it be better if both equipment are available in the OR and we can use it wherever we want of both technique? And he sort of said to me, well, that's possible with our instrument. It's possible with our equipment. I said, well, let's design an environment, an OR, to combine these two equipment together. So we went ahead and did the design of this Endo-Lap OR. At those days, laparoscopic theater was very common. But Endo-Lap OR means an environment where you can have flexible endoscopy and laparoscopic surgery performed at the same time with the equipment in common use. Example, the camera system is similar. So the instrument is what we call plug and play. You just stick your instrument into the machine and it works. So nothing to push from endoscopy suite, nothing to prepare the OT for. All the wirings is off the floor. It make it very efficient. And this is the first Endo-Lap OR. We did some work to look at what happened if you own or if you run the Endo-Lap OR. And basically found that this is published in Surgical Endoscopy at the time. These are the 30% reduction of workload of setup time. All right, 46% reduction in turnover time, and 60% reduction in time required to set up equipment, like pushing it from the endoscopy suite. That went on for 4 years before the robot came along. So our next project of Endo-Lap OR got to incorporate the robot. So it become robotic Endo-Lap OR, and we built that in 2009. So we're talking about these facilities being built almost 20 years ago, if not 15 years ago. And my vision was to have be able to use any instrument, whether laparoscopic, endoscopic, or robotic, as the instrumentation availability in the OR for us to perform the surgery for our patient. Now, since this is the upper GI course, I just concentrated on giving some example endo-lap surgery. Repair of PPU. Sometimes, you might not find the perforation when you put your scope in because of the pus and all the contamination. Why not stick a scope in to identify where it is? While you have a scope in the stomach and a laparoscope outside, you can identify your hole and repair it. So that's a useful use example of this condition. And again, this is a complicated peptic ulcer bleeding. GIST tumor, right at the cardia. Of course, this operation was done some 10 years ago already. And we were able to remove this gastric tumor under direction of the endoscope, put in trocars into the stomach, and resected this and repaired it. And that's a combined technique. Of course, you can also use it to do wedge resection by identifying where the tumor is and do extrinsic excision. And this is another large gastric intestinal tumor, can be safely removed using the combined technique. Further example of laparoscopic transgastric resection, all been published in the paper to show it works very well. And now we can have endoscopic enucleation. And combine endoscopic intragastric excision of gastric neoplasm. And this is the intraoperative trocars into the stomach. Instruments are being followed, and we then do the excision and closure of the defect. And of course, you can also do endoscopic resection of gastric tumor, cancer, early cancer, and do laparoscopic sentinel lymph node biopsy for early stage stomach. So combined technique is doing this at the same sitting. So I'm sorry the video didn't work, but not to delay the lectures, I would just like to say there's a great potential for the combined technique of endoscopy and laparoscopic surgery. And I must admit, APELS have been an organization that we formed with experts around Asia Pacific region to promote this applied technique to various disease processes in the gastrointestinal disease. And I'm very happy to see you all here to learn about how to apply this technique for your better use on your patient. Thank you very much indeed.
Thank you, Micheal, for that very nice integration of endoscopy and laparoscopy. I think it's a very nice lecture to start our sessions with, because we're going to now see a series of endoscopists coming in, laparoscopists coming in, giving a talk. But this integration is extremely important. And what we did, Micheal, is based on your paper in surgical endoscopy on this combined ORs where you combine laparoscopy. We actually created a hybrid OR, but this is an endoscopy area. So we have access because for some reason, if the endoscopists have to go into theater, change dress, and we feel very inhibited with all the things. Whereas it's easier for surgeons to come to endoscopy area because there's not so much of de-roping and all. So we created this, and it's been a very big hit now. So I think this concept that you created of a Endo-Lap OR, and now of course robotic Endo-Lap OR is a very important concept that's picked up all over the world now. Thank you very much, and I think we'll end this and go on to the next session.
Okay, good morning, ladies and gentlemen. My name is Xiao Chun Siong. I'm a surgeon from Singapore. I'm actually flanked by my co-chair, Dr. Mahesh Shetty. I'd like to start the first session. Our first speaker is Dr. Kriti Krishna. She's going to talk about approach to evaluation of GERD. Here you go.
Good morning, everyone. So I will be talking on the approach to the evaluation of GERD. It is a simple but pertinent topic. So as we know, the cardinal symptoms are heartburn, regurgitation, chest pain, that is esophageal type, with or without the presence of mucosal damage. It is basically a clinical diagnosis, and the Montreal definition does not require any objective evidence. However, the recent ACG definition requires the presence of characteristic mucosal injury at endoscopy or an abnormal pH impedance monitoring. So it is widely prevalent, up to 20 to 30%. When a patient presents with GERD and has the typical symptoms of heartburn and regurgitation with no alarm symptoms, the first step is actually to give an empirical PPI therapy, which is a single dose PPI, usually for 8 weeks, and it is reasonable to extend it for 12 weeks. However, if the patient presents with atypical symptoms or isolated chest pain, we will always evaluate this patient further. So these extraesophageal symptoms or the atypical symptoms include laryngeal symptoms such as globus, laryngitis, repeated throat clearing, and postnasal drip, while there are some pulmonary symptoms that they can present with a chronic cough and dental erosions, dental caries. So most of the guidelines tell us to involve a multidisciplinary team while treating this and to evaluate further before labeling it as GERD. So this is the Lyon consensus, where again they tell us to involve the other departments for evaluation of the atypical symptoms. We must also keep in mind overlaps and other diagnoses, other functional GI disorders. So when there is bloating and pain, consider also functional dyspepsia. When there is nausea, vomiting, and risk factors such as diabetes or post-surgical cases, look out for gastroparesis. Other functional behavioral disorders like rumination syndrome, where there is no nausea, retching, and simple regurgitation, and there is belching. So we must rule out rumination syndrome and supragastric belching. Then most important, if the patient presents with dysphagia, look out for motility disorders and eosinophilic esophagitis. So achalasia can present sometimes with predominant regurgitation and chest pain. So this must be kept in mind. We must also rule out other organic causes and cardiac chest pain also. So when we give PPIs, almost all of the patients have healing of esophagitis if present, and heartburn relief is seen in almost 75% of the patients, while chest pain relief is variable from 50 to 75%. So after the initial empiric treatment, if the patient does not improve, so we will go ahead with further investigations, which include an upper GI endoscopy, an esophageal manometry, 24-hour pH and impedance analysis, which can be done by a catheter-based test or a wireless pH capsule. So coming to the upper GI endoscopy, the indications, as I said, persistent symptoms and alarm signs. We must keep in mind that ideally an endoscopy for diagnosis of GERD must be done after 2 to 4 weeks of stopping PPIs, because PPIs will cause healing of the esophagitis even in short courses. So at that time, we can give the patients antacids during these 2 to 4 weeks. So on an endoscopy, there are certain findings that are diagnostic of GERD, and we need not do further testing for proving GERD. And these are esophagitis, that is grade B, C, and D, that is a mucosal break more than 5 mm, peptic strictures, and if there is a long segment Barrett's esophagus. So we can classify the patient then as an erosive GERD, which is seen in around 30% of the patients, and non-erosive GERD if the endoscopy is normal. We can also classify the morphology of the LES, which will guide our further endoscopic or surgical therapy. Coming to esophageal high resolution manometry. So this is done to identify the peristaltic pattern, to identify the LES morphology, to see the contractile reserve of the esophageal body, and to rule out other motility disorders. So we can see here the separation of the LES and the diaphragm in the image on the right side. So suggestive of a hiatus hernia. These will be shown in detail in the next talk. Now, almost 20 to 35% patients of GERD have ineffective peristalsis. So, what is the importance of this? Some patients with ineffective peristalsis, when they have undergone fundoplication, they do come back with dysphagia. However, this is a debatable topic, and recent studies have shown that there is not much effect of this ineffective esophageal motility in predicting dysphagia. So this is another technique that we do in manometry, where we give multiple small swallows and we see the augmented contraction after the swallows. This shows us that the contractile reserve of the esophageal body is there. So even if the initial swallow looks ineffective and there is a good MRS response, the patient may not have post-surgical, post-fundoplication dysphagia. So this was a study of 63 patients where they showed MRS helped to predict post-op dysphagia. And of course, we want to rule out achalasia and other motility disorders. Coming to 24-hour pH impedance analysis. So when do we do this test? When there is a PPI non-responsive GERD, when there are atypical symptoms for the diagnosis, and before and after surgery, as well as to see objective improvement. So this can be done by catheter-based tests or by wireless pH capsule. We have done a few cases here. So this Bravo capsule is placed around 5 to 6 centimeters above the LES, and it gives us an idea of the pH, but it does not give us an idea of the impedance analysis. So I will not go into too much detail. However, the main parameters that we look for are the acid exposure time, the number of reflux episodes, and the symptom association. So if the acid exposure time is more than 6%, it is definitive evidence for GERD. Then if the reflux episodes are more than 80 in number, then it is adjunctive evidence, and both of these together are definitive evidence, of course. And symptom association, basically two indices that are calculated, which give us evidence of the correlation of symptoms with the acid reflux. So then the patient is classified. So we can see on the left side, when there is normal acid exposure and there is no symptom association, we can classify the patient as a functional heartburn, and they would benefit from neuromodulators. When there is a normal acid exposure time, that is less than 4%, with positive symptom reflux association, we will label the patient as reflux hypersensitivity. And when the endoscopy is normal and there is abnormal acid exposure, so we can label the patient as a non-erosive reflux disease. And on the right side, we can see in a case of proven GERD also, similarly, they will be classified. So just a point to add that when we do a catheter-based analysis, we can also see the impedance. So we can classify belching episodes as supragastric or gastric. So this is a flowchart of, just to summarize, when we see a GERD patient, we first give empirical therapy. If there is response, well and good. If there is no response or there are alarm symptoms at presentation, we will do an upper GI endoscopy. If there is erosive esophagitis and a patient wants to take PPI for long-term, continue with lifestyle changes, we will maintain them on that. However, if they cannot, and if there's persistent disease, we can offer them endoscopic therapies. on 24-hour pH. If there is evidence of reflux and significant acid reflux, then and they are suitable for endoscopic therapy, we will take them up, or else we refer to the surgeon for fundoplication. And if there is functional heartburn or reflux hypersensitivity, we put the patient on neuromodulators. So the ideal patient for endoscopic therapies are those with symptomatic GERD that are dependent on PPIs, esophagitis grade A to C, with a small hiatus hernia, not too large. So 2 to 3 centimeters is good. And with a significant acid exposure time of more than 6%, the pH is less than 4. So this is a slide just to show the available endoscopic modalities. I'll not go into the details as this discussion is on the approach of the evaluation. So we have number of endoscopic techniques like radiofrequency ablation, transoral fundoplication, and mucosal resective and ablative techniques. Thank you.
Thank you, Dr.
That-
Priti, for your talk. So I request you to take care here so that we'll take part in the discussion at the end of the session.
Thank you, Kriti. I'd like to invite Dr. Aniruddha for his talk on manometry for upper GI motility disorders. Aniruddha.
Good morning. So my job is to ignite interest or in manometry for the surgeons in 10 minutes. It is very difficult. So why to choose manometry at all? So it is important to learn clinical decision making. So if you're operating on the patient, you're the best person to decide actually. And when you get the patient after the recurrence, after the primary therapy has been done, you are the best person to decide what has happened so far in his journey. So nowadays, advanced equipment and software actually helps even the non-experts, and there is an opportunity to be unique among all. So young surgeons can at least know the basics of manometry. So this is the esophagus, and the upper part is actually the striated upper part is the striated muscle, middle part is the smooth muscle and the striated muscle conglomeration, and the lower part is entirely smooth muscle. The lower esophageal sphincter is made by two parts on the manometry zone. One is the functional external sphincter, which is contributed by the right crus of the diaphragm, and the main one is the circular smooth muscle, which is continuous state of constriction and contributes to the development of lower esophageal sphincter on manometry. So this is simple. Upper esophageal sphincter opens, bolus passes, there is a coordinated contraction of the body, then there is a forward esophageal contractile front, and there is deceleration in front of the bolus. That's how a bolus passes. And LES relaxation starts immediately after the upper esophageal sphincter has relaxed. So for proper swallow to happen, both these sphincters should relax. So these are the common indications. The most common indication is to study esophageal motor function. However, you would like to work up the patient's pre and post fundoplication. Pre-fundoplication, whether the patient will be able to handle the fundoplication, either wrap should be partial or complete, or the post-fundoplication dysphagia workup. So there are two types of catheters. One on the left side is the water perfusion, on the right side is the solid state. Both of them are clinically similar. However, solid state is more sensitive in picking up subtle abnormalities and also has impedance sensors, which you can see as a gold ring, which actually designates the flow of the bolus from the upper esophageal sphincter to the lower esophageal sphincter. So in the nature, the color coding has already been done. So we are adopting the same in the manometry. So generally the colder meditating Shiva is looked as a blue color and depicted as bright red when he is angry. So same with the manometry also. So this is a normal topography, which is showing a normal wet swallow. Upper one is the esophageal sphincter, upper esophageal sphincter, followed by the striated muscle here. And the, sorry, I'll use a pointer here. Yeah. So the striated muscle relaxes, and then this one. Sorry. So the striated muscle relaxes and forms into the lower esophageal sphincter. Lower esophageal sphincter is here, and it relaxes as soon as the upper esophageal sphincter starts relaxing. So HRM with impedance, the pink zone, what you're seeing here is actually the bolus flow. So we do it on 5 ml saline swallow, and is useful for disorders like rumination, belching, GERD, or early eclasia. On achalasia, sometimes you might see the stasis of the fluid in the mid-esophagus. So this is a Chicago classification which we all follow. It takes around 20 to 30 minutes to do a complete protocol. I'm not going into detail. However, we give 5 ml, 10 swallows, then give some adaptation period, then give sometimes provocative maneuvers also to unmask subtle abnormalities. So pressure inversion point marking is very important. Actually, that is the zone where mediastinum transits into the stomach, and that zone is depicted as pressure inversion point. So beware of this pattern. When you have put in a catheter, you see whenever the swallow happens, the patient is swallowing and there are two pressure changes. So there is no pressure inversion point. This is called as butterfly pattern, which is seen mostly in folded catheters. The diaphragmatic morphology is very important to plan the type of surgery. And it is depicted here that sometimes both the LES and the crural diaphragm overlap, and that is being shown on the manometry, and they are separated. That is shown manometrically as hiatus hernia. So the IRP, which we see here, the lower esophageal sphincter relaxation, it is always less than 15, but always be aware of the equipment you are using. So if you're using Medtronic equipment and in the supine or the upright position, the thresholds are different. So in supine, median IRP should be more than 15 to call it as abnormal. In median IRP in Diversatec and Laborie machine is more than 22 actually. So you cannot label it as achalasia just on the threshold of 15. And additional considerations like IRP more than 12 on rapid drink challenge that we will discuss subsequently, and IRP more than 25 on Medtronic or solid test meal supports outflow obstruction. So the solid white lines, which you see here, are tangential to the peristalsis. And if you note that the onset of the swallow here till the peristaltic movement, which is called as contractile deacceleration point, is the distal latency. So if it is less than 4.5, it is normal. More than 4.5 is normal. Less than 4.5 is the premature spasm, and the contractile integral should be more than 50. 450. So these metrics are already available on the machine. We need not manually calculate. So the vigor of peristalsis should be around 450 to 5000, which is calculated by the machine automatically. If it is exceeding more than 8000, it is called as hypercontractile swallows. And the wavefront velocity, the brakes should be always less than 5 centimeter here. This one. So signs of abnormal bolus transit are actually the distal esophagus if it is poorly compliant and not relaxing. If there is compartmentalization between the peristalsis and the esophagogastric junction, like you see here on the left side of the red zone, that is the isobaric contour. And there are certain provocative maneuvers like multiple rapid swallows, rapid drink challenge. You do this when the standard manometry has not unmasked the problem and you suspect strongly that there is dysphagia, my patient is having clinical symptoms, so you do these additional maneuvers. So on the left side of the manometry, it's a normal 5 ml wet swallow. On the right side, it's rapid multiple swallows. So you give 2 cc of saline multiple times, at least 5 times, and get a large contraction here. If the patient is having peristaltic reserve, they are less likely to develop dysphagia on post-fundoplication surgery. If they don't have adequate peristaltic reserve, that means you have to do a partial wrap, although the data is conflicting. So rapid drink challenge is actually to ask the patient to take 200 ml of liquid, and then you see the response of the mid body of the esophagus, which relaxes completely, and also LES relaxes completely. If there is the paradoxical contraction of the lower esophageal sphincter, that means you are dealing with some sort of achalasia or early development of esophagogastric junction outlet obstruction. So as you see on the left side, it is looking like a type 1 achalasia, but when you do provocative testing, the contractions increases. There is panesophageal pressurization in the mid body of the esophagus, suggestive of type 1 or type 2 achalasia on rapid drink challenge. So on the left side, there is ineffective motility. You label them as ineffective motility and they end up doing partial wrap. But however, if you do proper MRS, that is multiple rapid swallows, you see that the patient has good peristaltic reserve and it's a healthy subject. So there are 3 types of achalasia. Essentially, on the left side, you see it as type 1, which is absent peristalsis with increased LES pressure. In the middle one, there will be panesophageal pressurization, and on the right, there will be premature spasms. That is labeled as type 3 achalasia cardia. I am not going into subtle details of these diagnosis. So on the left side, this is a common example. You see type 1 achalasia type of pattern. And but the IRP is borderline, like 10.8. So you should not draw the thresholds like above this. Suppose if you find out IRP as 15, you cannot comment it as achalasia or it as normal. So you need to do additional provocative maneuvers. and support it with some adjunct data like timed barium esophagogram or the Endo-Lap, which will be spoken to you by Dr. Rakesh in detail. So there are certain minor manometric abnormalities like esophagogastric junction outlet obstruction. So all these has to be carefully inferred upon. So manometric diagnosis is always inconclusive. You get a lot of reports like EGGO and refer to us for POEM or some sort of definitive endotherapy. However, you should be careful that most of the patients are just incidentally detected on GERD patients, and you should support it with some sort of adjunctive test like timed barium esophagogram or the Endo-Lap. And then only if the patient has typical symptoms like non-cardiac chest pain or dysphagia, you can label them as having significant EGGO. It's similar with the ineffective esophageal motility also and absent contractility. So on the absent contractility, if you find adequate contractile reserve, that means you can do a full fundoplication, otherwise go with partial fundoplication. Distal esophageal spasm and hypercontractile esophagus, both are actually minor peristaltic abnormalities, but still has the same thing, like they should have significant non-cardiac chest pain or dysphagia along with manometrically conclusive diagnosis. So hypercontractile is actually not synonymous with jackhammer. So you can divide it into single peak jackhammer and also hypercontractile lower esophageal sphincter. There is a lot of heterogeneity. So always be cautious in your approach. Conservative management is the best management, followed by endoscopic and surgical if the patient is severely symptomatic. So this is the summary slide. And when we perform 10 swallows, I would like you to look at the right side if there is abnormal median IRP. If the answer is yes, obviously it is achalasia. If it is no, you have to do wet swallows, do elevated LES IRP testing in varying positions like supine or sitting position, and then based on that, you have to make your conclusion. This is one important thing that there's a 54-year-old gentleman with dysphagia to solids and liquids, and on RDC, that is rapid drink challenge, we see panesophageal precipitation just looking like achalasia. However, this patient had history of esophagojejunostomy, and when we correlated with endoscopy and timed barium esophagogram, this patient actually had a pseudo-achalasia and had tumor development in the lower part of the esophagus. So understand the limitations of your device, know the normative thresholds in varying positions and also your devices. Don't ignore the auxiliary data and consider complementary testing as important, not a waste of your time. Thank you so much.
Thank you. Okay, the next speaker is Dr. Rakesh Kalapala. He's going to speak about one of the latest topics in upper GI, namely the Endo-Lap. Here you go.
Okay, so thank APELS and Dr. Jivira and his team for giving me the opportunity. So how many of you know Endo-Lap or rather have Endo-Lap in your units? Okay, so I think that makes my job easy. So Endo-Lap is basically a new kid in the block of armamentarium of GI motility testing labs. But again, that's not really new because it's been there from past 10 years, but the new version has come this year, or last 1 year across the world. And in India, it's soon going to be launched this month. And probably we are proud to launch it soon in the next 1-2 weeks. So coming to Endo-Lap, so the main mechanism behind this is the volume distension, which you measure by a parameter called distensibility. And we have seen these with a couple of devices, which of course I haven't seen personally, but the barostat, hydrostat, and now this is called functional lumen imaging probe. So the main characteristics of this Endo-Lap is it will measure the distensibility and also the changes in the volumetric distension when you fill the balloon or distend the balloon with kind of a conductive fluid. And this is important to measure the sphincters anywhere in the GI tract. It can be a pyloric sphincter, it can be the lower esophageal sphincter, or even anal sphincter. Of course, we don't have data on that, but any sphincter in the GI tract, it can measure the volumetric distension. And it also measures the distensibility in real-time image, which is more important because what Aniruddha has shown in the manometry is a 3D reconstruction image, but this is more of a real-time image. And as manometry does, it also has got extensive established evidence in diagnosing various motility disorders as well as GERD. So how it works is impedance is something which is a word in physics. What we have to understand is it is the effective resistance what we measure through a current flow of an alternating current in the body, in any tissue in the body. So you can measure impedance in any part of the body tissues. So what Endo-Flip does is it will detect the dynamic changes in the volume by volume distension in the esophagus and even in the lower GI tract through this impedance mechanism. And how it works is it will measure the esophageal pressure and dimension. And with this, you will get an index called distensibility index and cross-sectional surface area, CSA and DI. These are very important. What is being done is you have a catheter, which a balloon, which is, I'll just show you the next slide, what are the two types of catheters. And you put in inside, and for example, the upper GI tract and esophagus, then you inflate the balloon with dedicated fluid, which is conductive fluid built within the apparatus. And then once you distend, then you will measure the real-time geometric image of this. For example, it looks, of course, this is a newer edition, the newer version. The older version looks a little different. So this is how exactly the graph looks on, where you have this distensibility index, cross-sectional area, and other parameters. So the two catheters which are available in the new version, or one is a 16 electrodes, about 8 centimeter, and one is 16 centimeter. Probably the 8 centimeter one has been designed for people who are short stature or even in the adolescents and kids. But usually the conventional one, which is readily available now in the market, is a 16 centimeter. Various disorders where you have established role of Endo-Flip is one, of course, the dysphagia, where you measure the distensibility index and contractile pattern. It is also useful in diagnosis of eosinophilic esophagitis, where we really depend on biopsy. Then surgery or fundoplication, if it is endoscopic or surgical, pre and post, the adequacy of the esophagogastric junction distensibility. Eclasia diagnosis as well as therapeutic, where post-op or intra-op you can assess the the distensibility of the esophagogastric junction. Then GERD, as I told you, again with these parameters, and also in strictures when you dilate intra-op, again this is of great use. So normal findings, of course, these are again different for each set of people. Probably Indians have different distensibility. We need to do normal healthy volunteers data come on that. But this is one data from the Western world published in CGS in 2019, where the main point is greater than 2.8 of the EGG junction distensibility is considered as normal, and less than 2 is considered as abnormal. Then you also have, according to that study, in a set of population of that cohort, where you also measure the distal esophageal body distensibility and maximum EGG diameter. And this is one proposed parameter of cutoff of 2 mm square per millimeter mercury with after distending the balloon up to 50-60 ml. So this is what has been in that cohort of study, but we need our own normative values. And typical interpretation, like how the Chicago classification is, of course, it's to evolve, but in short, what you have to keep in your mind is the esophagogastric junction distensibility index, if it is less than 2, it is abnormal. And if the EGJ diameter is less than 13, as I told you, it's 18 is normal, again is considered abnormal. And there is something called as repetitive contractile retrograde contractions. If they are absent, also is again an abnormality. And as you see on the screen, likely abnormal, intermediate, and normal. So this is how we have to interpret the Endo-Flip when you start doing it. And this is again, the maximum work has been done by John Pandolfino group from Northwestern University. And this is one classification what they have proposed as rule of 6. But again, this is for that cohort of patients. As of now, we have to keep this in mind and then start validating our patients, but we have to have our own data. So the main difference between the manometry, what Aniruddha told, and this Endo-Flip is, there are a couple of advantages also of Endo-Flip compared to manometry. One is it will measure the distensibility of as a diameter, and also it can be done in any patient who is also not cooperative. What I mean to say is you can do endoscopy and then followed by that manometry in the same, Endo-Flip in the same sedation, rather than waiting for the patient to awake, and then obviously manometry is a little more bothering because not every patient is cooperative. And the main differences between this is, as I told you, balloon inflation of the esophagus is something which will be the main thing in endo-flip, whereas it can be a solid or a liquid state manometry with catheter inside. But one difference is because the catheter of the manometry is long, you can measure simultaneously the upper esophageal sphincter and lower esophageal sphincter. Whereas for this, you have to do some graded way of doing a lower esophageal, then taking it up and then measuring the mid end of esophagus and lower end of esophagus. So in toto, how exactly it looks is something like this, where the impedance planimetry versus manometry. So this is how the pressures have been categorized on manometry, whereas endo-flip, you measure it in distensibility index and cross-sectional area. I'm not going into the depth of this because this is again in the evolution form, but what Medtronic has proposed this or these classifications of absent contractility, then disordered contractile response, then you have the low EGAG distensibility index and strong occluding contraction. These are different terminologies which they have proposed, and once you do it, then you will know what exactly it means. So the key take-home messages with endo-flip is, one, it will measure the changes of the dimensions. Second, it also will exclude esophageal motility disorders at the same time when I do endoscopy in the same sedation, rather than subjecting the patient for the HRM or other barium esophagograms, which very seldom we do. And third, if at all endo-flip is normal, so the current validation studies comparing HRM and endo-flip, they're almost same. And it expedites the clinical evaluation. You don't have to send the patient to a GI motility lab. You can do as an endoscopist then and then on the same table, same sedation. And it also improves the diagnostic yield of endoscopy because it's going to complement your endoscopic diagnosis. This is again the older version. In fact, we had our own personal experience 6-7 years before. This is the old generation endo-flip, and this is how the graph used to look. We had our own publication where we measured the pyloric sphincter normal physiology. This is basically done at our institute out of academic interest because we work on a duodenal pyloric sphincter duodenal device for diabetes. So then we just use this device to have a healthy volunteer normative data. And we had these data, as you see on the screen, 20 ml, 30 ml, 50 ml, 60 ml distensibility. And this is again the classification by John Pandolfino group. So you have certain terminologies which they have coined in the normal contractile response, borderline contractile response, impaired or disordered contractile response, absent contractile response, and spastic response, that is jackhammer. So this is in a nutshell about endo-flip, and I think once we start using it and more data comes on, we have studies which have been published, but again in the Western world, I didn't touch upon because of a shortage of time. But the take-home message should be that it is at par with HRM, and in few cases it is better than HRM, and it can be done with endoscopy simultaneously under sedation, and is more comfortable for the patient because it is done under sedation than an HRM which is done in an awake patient. I'll stop here and thank you for the opportunity.
Thank you, Rajesh. That was an informative talk. Can I request you to join us on the podium for question and answers? And I would like to request the next speaker, Dr. Zaheer. He will be speaking on clips in practice.
Good morning, all. So I'll be speaking about what are the different clips and what are their properties which are commercially available and how to choose among different endoscopic clips. So bleeding and perforation, there are two main complications that any endoscopist fears of, and I think clips are useful in for managing both of them. So in the next few slides, I'll be talking about different closure devices, the technique of closure, whether it's through the scope clip or over the scope clips. So there are different closure devices. You have routine endoscopic clips, you have over the scope clips, you have suturing device, and more recently you have newer devices like hand suturing needle and X-Tack. So we'll concentrate on endoscopic clips. So is there any difference between different endoscopic clips? The answer is yes. Not all clips are same. And when I say so, what are the important differences between different type of clips? The clips are different not only in their opening width, tail length. All of these parameters are relevant when you you choose a clip and plan to close a defect. The length of the clip, the rotatability of clip in straight as well as strain position, overshooting, the precision by which the clip opens and closes, the tensile strength, and the strength of tissue compression. So this slide is just a comparison of some of the commercially available clips, the important differences between width, jaw length, clip length, tail length, etc. But what's more relevant to me is the different dimensions of the clips. So now we have clips which have a wider jaw opening to close wider defects. So we have clips as wide as 17 millimeter in width, so to close different defects. So this slide is probably the most important slide of my talk. And why I say so, because based on these parameters, you decide that which clips should be chosen for defect at which place and at which position. For example, if I compare these clips, some clips have good rotatability in normal and strained position. And what do you mean by strained position? For example, you have to close a defect in retroflexed scope position. So you need a clip where rotatability is good even if the scope is bent. Similarly, there are clips which have good tensile strength. So I'll use those clips for closing thick mucosal defects. For example, gastric mucosa is really thick, thicker than other parts. So I'll use a clip which has good closure strength and which has good lateral manipulation capacity. So this slide, just to a summary slide of which clips should be chosen for what type of defect. For example, resolution clip, which is a very commonly used clip. It has a good rotatability in strained position. So I'll use at a position where my scope is bent, or with the use of a duodenoscope, this clip will be really useful. Some other clips, they have other properties. So based on these properties, I'll choose my clip for that particular defect. Now, what are the techniques of closure? The most commonly used technique is zipper technique. Zipper technique is you start working on one end and then finish at the other end. So this is the most simple technique of closing using a through the scope endo clip. But what about larger defects? This technique is good for smaller defects. But if you have a larger defect, then you have to either use a different clip or different strategy to close the same defect. Now, what are the different strategies to close? So with the same clips, you can close larger defects also, but the technique will be different. So let's see what are those techniques. This is a simple endo loop, which is commonly available commercially and available in different sizes. So this loop can be used to close larger defect. What you need to do is carry this loop inside, and apply the clip around the loop along the margins of the defect and close the loop, just like purse string closure technique, or also called as king closure technique. Very effective technique and one of the most commonly utilized technique in my practice to close some of the defects which are as large as 3 centimeter in size. There are other techniques also, clip-on-clip technique, clip-in-line technique. I won't go into the details, but these are techniques which help you in closing larger defects using the same through the scope clips. What about special clips? Are there any special clips? So these are some of the clips which have revolutionized the management of defects closure. And why do I say so? Because these are recently available, and some of these clips, for example, the one which is available from Microtech, you can open both the prongs separately. This helps you in manipulating one of the incision edges towards the other side and helps you in closing larger defects. So this is something which is a very unique property of this clip, which is not present with any other clip. The other clip, which is also a newer clip, which is Mantis clip, still under clinical trials. This has a very good sharp jaws, and what happens is it also helps you in manipulating one edge towards other. So your clip won't slip. You'll be able to close larger defects securely and without any undue difficulty. Let's see what are the other techniques. Now we have another clip which is called over the scope clip. Of course, we have suturing devices. I won't be discussing about suturing devices, but over the scope clip. What are the advantages of over the scope clip? Look, all these clips which I have just showed you, they are through the scope clips and they don't allow full thickness closure of the defect. And this is one of the main argument given by surgeons that you are not doing a good job by closing just mucosal to mucosal apposition. So over the scope clip is an answer to that. It allows closure of up to 2 centimeter defect size, and it allows full thickness, means all the GI wall layers will be included in that closure. So that's the main advantage of using over the scope clip. Now we have talked about clips. clip is not the only factor. The type of clip you choose does not mean that you'll do a successful closure. So there are various factors which affect your success of your closure technique. And what are these factors? Location of the defect, the size of the defect, the devices that you use, and the technique that you use. So if you see the different parts of GI tract, stomach, rectum, esophagus, colon, and small intestine, you'll see that they differ in their lumen size, the maneuverability of your scope, how easy you can maneuver your scope, the thickness of the wall layers, the lumen, whether you have a wide lumen or narrow lumen so that you can position your scope. So they're all different. So your success depends on where you are closing that defect and what technique you are using for that particular site. So to summarize what we have talked, there are different type of closure clips, closure techniques. We have through the scope clips. We have special techniques using the same through the scope clips. We have special through the scope clips like the DAD clip from Microtech, the Mantis, which is now recently available from Boston Scientific. Over the scope clip is a very useful addition at places where you want a very secure full thickness defect closure. For example, in second part of duodenum, if I have a defect, because the defect is constantly exposed to biliary and pancreatic juices, I would like to use over the scope clip. The reason being it allows a very secure closure and there won't be much of worry for leakage of any contents. How to maximize your success for closure? The first thing I always ask myself is closure really required? Some of the partial thickness defects, they don't really require closure. And just a conservative management by keeping the patients nil per oral and doing some RT aspiration will be sufficient. The size of the defect, the location, and your freedom of scope movement will decide that which clip you choose and which technique of closure you choose. You should always anticipate the difficulty in closing all these defects. It's not always easy to close these defects because some of the defects are at strange positions. In a strained position, it will be difficult to close. Look at the availability and expertise, which clip is available to you, and what about the closure technique that you are going to apply. So small defects can be closed by simple zipper technique, but for larger defects, you have to use a special technique like loop and clip technique. Always remember, whenever you are stuck, call your boss. That's all from my side. Thank you.
Thank you, Dr. Nabi.